Good evening. I'm Dr. Allan Perel, and this is Conversations in Medicine. This program brings cutting-edge topics to the Staten Island and New York City community, and the entire tri-state community. What we're going to be speaking about tonight is diabetes mellitus, a common, very common condition. And I have a wonderful guest who's an expert in the field, a very good friend, Dr. Philip Otterbeck. He's the chairman of the Department of Medicine at Richmond University Medical Center, where I practice. And also he's the head of the Division of Endocrinology at the hospital. And someone who's done this for a number of years and is really very expert in the field of diabetes. So welcome.
Thank you.
Let's jump right in. What does the words diabetes mellitus mean?
Diabetes can be diagnosed by blood tests. It's a condition where patients have high blood sugar. And the question is, well, what is high? If a patient does blood work and their fasting sugar is above 126 on 2 occasions, we say that patient has diabetes. If they do what we call a glucose tolerance test, they take a small amount of soda that the doctor would prescribe, and then we see how that body responds to that soda drink over the course of 2 hours. If it's above 200, we say that patient has diabetes. And finally, we use a test called the hemoglobin A1C, which is a blood test that you don't have to fast for. And that tells you how a patient's sugar is over the course of 3 months. If that A1C is 6.5 or greater on 2 occasions, that patient will also be considered to have diabetes. So basically, it's a disease of being too sweet, that is too much sugar, we call in medicine hyperglycemia.
So tell me, you said 2 occasions. So getting one high blood sugar test or hemoglobin A1C really doesn't confirm the diagnosis. Why do we need 2?
We need 2 because sometimes there are things that artificially raise a patient's blood sugar. So if a patient goes for a blood test and is driving to the blood test and all of a sudden gets into a car accident or gets into a fight with either their family members or someone on the road, and that never happens on Staten Island. But in any event, when those events happen to us, that raises some of our hormones in our body. It raises the stress hormone, which is cortisol. It raises the adrenaline, which is in the blood, which is from the adrenal gland. It even raises growth hormone, which is from our pituitary gland. And those 3 hormones together raise our body's blood sugar. So if a patient has, say, a stressful event on the way for a blood test, especially a fasting blood test, that can artificially raise that value and give us a false reading. So we repeat the fasting blood sugar twice. But there are also conditions like a hemoglobin A1C, which is not susceptible to 3-month sugar number. It's not necessarily susceptible to the same stressors as a fasting blood sugar would, but on the other hand, there are things that do affect the hemoglobin A1C and artificially raise it. A variety of those things can be if a patient is on a medication called prednisone, which is a steroid for some other reason. Temporarily, that can artificially raise the level. So it's important when we're going to give people this diagnosis that we make it with certainty, and that's what the 2 values gets us.
So once you have diabetes, is it a lifelong condition?
Diabetes doesn't go away. It can be managed. So once the doctor says, okay, you have diabetes, well, you have diabetes for the rest of your life, and you can have diabetes in a variety of flavors. You can have poorly controlled diabetes where the sugars are too high. Or you can have well-controlled diabetes with medication where you have a good sugar level, but you're taking a bunch of medication. But you can also have good, well-controlled diabetes and not be on any medication. That's obviously the best situation to be in because you're able to manage the condition with just diet and exercise. But all 3 groups would be considered to have diabetes.
A lot of my patients like the term or use the term pre-diabetes. Borderline diabetes, hyperglycemia. Why don't we try to define them and give us an idea? Are those real words? You know, as a neurologist, people will say, I had a mini stroke, or I had a little episode, or a TIA. And sometimes these episodes are never very well documented. I'm not sure whether they really had one of these episodes. And it's hard to distinguish, say, someone with blurred vision from a migraine versus having a mild event that lasted, 2 or 3 minutes, especially if it happened a few years ago. So when I hear all these words, and especially if someone's not on medication, and they're on diet control, whatever, tell us a little bit about pre-diabetes or hyperglycemia, what it means to us.
Well, prediabetes is as you know, a pretty well-defined term. Now, I have patients that tell me, doctor, I have a touch of diabetes.
Right.
But their touch, I mean, they're on 3 or 4 different drugs to control their blood sugar. So their touch is not, that term is not a medical term, and it's probably not consistent with the disease state that they have. It's maybe how they perceive what the doctor has told them in the past, but it's an imprecise term and we probably shouldn't use it. Something like pre-diabetes, however, is a very well-documented term. And going back to our fasting blood sugars, when a patient gets their blood test taken, if the sugar is between 100 and 125 fasting, that's considered pre-diabetes. When it's at 126 or above, that's diabetes. So essentially, the pre-diabetes state is a preclinical condition, but it is not innocuous. People that have pre-diabetes are at higher risk for things like cardiovascular disease, stroke, neuropathy, even from a pre-diabetic state. So when a patient is told he or she has pre-diabetes, that should be the sign for the patient to say, okay, let me stop. I have to think about my life and think about the things I need to change. And what specifically can they change? They can change their diet and their exercise programs. So pre-diabetes is certainly a well-defined term, and what I like to tell my patients is please take it very seriously, because you don't want to progress to the diagnosis of diabetes, wherein most of the time patients need pharmacologic management.
So I'll ask you diabetes type 1 versus type 2, and maybe I'll even say it in a different way. I'm sure every patient that you diagnose with diabetes has one word that they're afraid of, and that's insulin.
Yep.
Getting injections. So tell us a little bit how you put that together, because again, diabetes type 1, maybe by definition, you'll tell us what the difference between the two are. But should everyone be afraid, and who needs insulin and who doesn't need insulin?
That's a great question. Type 1 diabetes is a very, very different disease than type 2. In type 1 diabetes, it is an autoimmune process by which the body is essentially attacking itself. We look for basically the anti-pancreas antibodies in a patient's blood to make that diagnosis. And what happens in type 1 diabetes is those antibodies attack the cells of the pancreas. We call them beta cells. The beta cells are the insulin-producing cells of the body. And when the body attacks those insulin-producing cells, the body becomes unable to make insulin. And thus, patients, insulin is necessary for life, and without giving insulin from the outside, patients would die. And sadly, that's what did happen to many patients before the production of, or the discovery of insulin therapy. So those patients, the type 1 patients, are dependent upon insulin for the rest of their lives. And that, and we can talk about it a little bit later, can be delivered either via injections or by an insulin pump. Type 2 diabetes patients are a bit different. In type 2 diabetes, they have their main problem, or one of the main problems they have, is insulin resistance. So you or I, we eat two people eat the same ice cream cone, say. One patient will need 2 units of insulin to normalize their blood sugar. Another will need 6 or 8. And the individual that needs 6 or 8, we call them insulin resistant. And over time, the pancreas tires out of having to make all that insulin. And what tends to happen is the blood sugar tends to rise. Now, the great part of those patients is that they don't have a true or complete insulin deficiency. So we're able to get away with giving them diet and exercise advice, of course, but on top of that, other pharmaceutical agents that will assist their body to make more of its own insulin, as well as process sugar in a more effective manner.
So very complicated, but clearly from experts like yourself and internal medicine physicians, there's sort of models and how to use it, what medicines to use, and some guidelines in order to do this. Maybe I'll even just as an aside, there's been so much in the press about insulin and the cost of insulin over the last couple of years, that there's not available insulin. Insulin is prohibitively expensive. Patients are petrified of running out of their insulin. I mean, we're seeing this now with formula. But with insulin, it's been going on for a couple of years now. Is that the case?
There are a variety of different types of insulin. And unfortunately, when issues like costs of medicine kind of make their way into the political sphere, a lot of things kind of get blown out of proportion a little bit. Now, there are expensive insulins out there. The brand insulins are among them. And those brand insulins, which are the newest, probably the latest and greatest insulins, those are the ones that are, if you look on goodrx.com or you go to all these websites, you can see the price, the retail price of these insulins can be $400 to $500 a month, which of course is exorbitantly expensive, especially if patients have no insurance or if they have, Medicare plans where they're paying 25% of the drug's cost, which can be a challenge for those patients.
Sure.
But fortunately, for many, many years, there have been available a lot cheaper insulins that you can get in Walmart and different places like that. And I'm sure, Dr. Perel, you'll recall when it was these insulins were very commonly used, the NPH insulin and insulin R, regular insulin they call it, and these are very, very cheap, maybe $30, $35 that patients can buy out of pocket. So there is availability for cheaper insulin. So no one really should ever have to go without insulin completely, but it does remain a big problem for patients of getting the latest and the greatest insulins, the flatter insulins, the ones that have less of a chance of a low blood sugar or hypoglycemia. Those can be out of reach for some patients, sadly. But patients, especially type 1s, would always have access to reasonably priced insulin.
Do you think it's the physician or healthcare provider's guidance with this that's not been mentioned in the press, or is it the patient's difficulty using some of these older insulins? And again, older doesn't mean bad necessarily, of course, but the idea, people keep talking about this, and we see this so many places that people can't afford the insulin. And here we're seeing relatively low-cost insulins, as you mentioned. Is it the doctors not being able to guide the patients, or healthcare providers not being able to guide the patients, or is it just the difficulty with the patients themselves?
Well, of course, we always want to use the insulins that are working the best with the least risk to the patient, the least hypoglycemia. Sometimes doctors can be unaware of some of the availability of some medicines. One of the things that comes up a lot in my field is not only with insulin, but also with the other diabetes drugs that I use, is they tend to be very expensive. And of course, the people that struggle, people that, as you know in your practice, people with private insurance do very well. They can use coupons, they can get medications very, very cheaply. People that have Medicaid pay very, very little for their prescriptions, sometimes $0, sometimes $1 to $3 per prescription. The two groups that I struggle with in my practice are people that either have no insurance or those that have Medicare. And a lot of the Medicare plans, the Medicare Part D plans, they do make patients pay 25% of their costs. So there are ways to get extra help, and one of the ways to get extra help, actually in this state, the state of New York, there's a program called EPIC. And I'll tell a lot of my patients to sign up for EPIC program, and it's a pretty generous program in terms of the assistance they'll give the patient. And patients and their spouses, especially if they have some income threshold that everybody can look up on their own, because it, of course, depends upon the number of people in your family and your income. So those parameters are there. And then also, drug companies actually are quite generous in terms of giving away free medicine. Those programs have income thresholds as well. But the patients, if they can go online, they can Google the company that makes the medicine. They can find out what drug they're looking for and the company's income requirements for their charity program. So there are lots of different creative ways of finding the medicine and getting the medicine. It requires some effort and some work, but certainly as providers, we need to be aware of those programs. And sometimes, if there's a new program, we might not be aware of it straight away. But certainly they have to give the message out to us, and then of course we would be happy to deliver that message to our patients because that's what they need.
So let's jump all the way back. So someone
Yes.
was diagnosed with diabetes recently.
Yes.
Most of our patients, we said, were very concerned about having to go on insulin. Most people don't want to take shots or subcutaneous injections or any kind of injections. Tell us about the oral agents that are available, and then maybe we'll work our way even to some of the other injectables that are there. Because if you watch television, it's sort of, when I get home at night, I like to watch a sporting event or I like to watch anything. And the number of commercials with regard to pharmaceutical agents, drugs that are available is huge, and so many of them are in the diabetes sphere, with diabetes mellitus treatments. So tell us a little bit about some of these medicines, and when patients come in, I think you once said this to me last time when we spoke at your office, that some of the patients come in wanting one medicine, but they really are on the same kind of a medicine, but it just it's a different brand. Yeah. So tell us a little bit, and let's try to make something very complicated somewhat simple. Like, what are the first-line drugs, and most people know about metformin, and how things progress, and what do you do?
So my toolbox over the years has gotten bigger and bigger and bigger, and I'm certainly very happy to have more tools in my toolbox to treat diabetes, because there are people that come to me in all stages of the disease, very early or very late in their disease, and the more ways I have to help them, the better for me, and better for them. The base of our diabetes management has been metformin. The great thing about metformin, it's cheap, it's effective, and there's no low blood sugars or hypoglycemia. As a second line of therapy, there are so many agents that we have to select from. In terms of pills, I think I want to talk about this class of drugs. This is the newest oral agent, newest class of oral agents, or the SGLT2 inhibitors. And these work at the kidney, and they essentially work by making the patient pee out sugar. And it binds to receptors in the kidney and prevents the reabsorption of sugar and sodium.
So in a sense, because you have too much sugar in your blood, if you urinate out or pee out a lot of sugar, there's less in your blood.
Exactly, exactly. And what happens when you lose sugar in the urine? You also lose calories in your urine. And when you lose calories in your urine, you lose weight. So these drugs, SGLT2 inhibitors, and the brand names that I'm sure the audience sees on TV, Farxiga, Jardiance, Invokana, Stiglatro, those are the four. These drugs are marketed to help diabetes patients, but this is how they work. They're working at the kidney to make you pee out sugar. But what's remarkable about these drugs, I'm certainly happy that they help patients' sugar go down. I'm also very happy that I see the patients lose weight. But what's additionally remarkable about these drugs is there is great prospective data, great data to support the fact that they prevent heart problems and, in fact, cardiovascular death, and also they protect the kidney from diabetes. So they're working in the kidney, and they protect the kidney from diabetes and the progression of kidney disease. So these really have come onto the scene. I think it was in 2013, and they have really come on the scene and really revolutionized the way we treat diabetes and its complications.
Do you use it earlier because of the benefit with regard to cardiovascular risk factors?
Absolutely. They have, if I have to go to a second line of therapy, those are right at the top of my list in terms of my selection.
Yeah. Tell us a little bit about some of the injectables other than insulin.
Well, exactly, and that's, a lot of patients get this wrong. They'll tell me, doctor, I'm on 3 different types of insulin. So I'll look at the list of things, and I'll say, okay, they're on this insulin, that's correct. They're on this insulin, that's correct. But they're also on another injectable that's either once a day or once a week. These are injectable agents, injectable medicine, but not insulin. And the way these drugs work, we call them GLP-1 receptor agonists. And what do these drugs do? They work at the level of the pancreas. They make the pancreas pump out more insulin. And they work at the level of the brain in the hypothalamus to tell patients they're satiated, they're full, and so they don't eat as much food. So, and additionally, these drugs help patients lose weight. But just like I talked about those SGLT2 inhibitors protecting the kidney and protecting the heart, these drugs have been demonstrated to also specifically protect the heart. So if you ask me, what are my drugs of choice when I see a patient with diabetes, first it's metformin for the reasons I talked about, but as a second line agent, those GLP-1 injectable agents or the SGLT2 inhibitors certainly will be both number 2 and number 3. And that seems a little strange, right? Injections early on, but the potential to protect that heart, to have no low blood sugars, no hypoglycemia, and weight reduction with both of those agents is really a great combination along with metformin.
And if that doesn't work, if you need insulin, you need insulin. Sometimes you try everything, it just doesn't work. Maybe just real briefly, you were talking about what patients and viewers are going to say, why do you need 2 kinds of insulin? I mean, clearly there's, you'll describe it. I won't even, I'll let you start from scratch. But why do you have two different kinds?
So we have two types of insulin generally. The general way to think about it, one is long-acting insulin, one is short-acting insulin. The long-acting insulin controls the body's blood sugar in the morning, right? It lasts for 24 hours, but its the way you ascertain whether the dose is correct is by looking at the morning blood sugar. And how does that affect? It controls the liver's output of sugar. So that 24-hour insulin, the long-acting insulin, controls mostly what it does is it controls the liver. In terms of short-acting insulin is for a meal. Everyone can understand that when you eat a meal, the sugar goes up. And of course, when you get high blood sugar, that can cause a problem. The whole idea of giving a short-acting insulin with your meal is to prevent the spike in your blood sugar and thus maintain what we call euglycemia, or normal blood sugar.
What do you think about people for just weight control, not people with high blood sugars, using any of these medicines for weight loss?
There are several approved drugs for weight loss that are available. We talked about the class of drugs, the GLP-1 receptor agonists. Although I mentioned them in the context of diabetes, there are two GLP-1 receptor agonists. One is called Wegovy, and one is called Saxenda. And these are two injectable agents. One is a daily injection, one is a weekly injection. And these drugs are very effective at helping patients lose weight. So what do I think of them? If a patient is doing a good diet and a good exercise program, these can be very useful adjuncts to helping patients achieve their target weight and target BMI.
Tell me about the team that you work with. A lot of times people will come into the office and see you, but talk about the nutritionist, the nurse, the whole team approach to someone with diabetes. I've seen that with, as you mentioned, with me with multiple sclerosis. We have a whole center. I've got a social worker, I've got physical therapists, nurse practitioners, people to look at different aspects of the case. Tell us a little bit about that with diabetes and why you think, and who needs to go to someone beyond their primary care physician or healthcare provider, to someone for this whole team approach with nutritional guidance and things like that.
Whenever I think about diabetes and what types of patient, by whom can they be treated, at least in terms of the primary physician or provider taking care of them, I always go back to thinking about, well, how many patients with diabetes do we have in this country? And the most recent data that I have is about 37.3 million patients with diabetes. And I also think about the fact that there's only about 7,000 practicing endocrinologists. So you can imagine, looking at that ratio, that there's no way in the world endocrinologists can manage these patients. So most of these patients are going to have to be managed by their primary care providers, whether that's a physician, whether that's a nurse practitioner or PA. These patients need to be treated at the primary care level, at least most of them. The patients for whom endocrinology referral is indicated are the ones that have more advanced disease on multiple different medications and are still struggling to achieve normal blood sugar. In terms of a team, I would say that every patient with diabetes should be seen by a nutritionist. And the great part is insurance will in fact cover those visits. Whereas they won't cover that for patients before they get diabetes, they will cover it when they do get diabetes. So that is an important referral for patients. But we also we work with a team of ophthalmologists, podiatrists. Patients with diabetes have problems with their eyes, or they have problems with their feet. We work with that team. We have a nurse practitioner in our practice that will see patients and more frequently than maybe the physician can see the patient, so that we can do insulin titration, going up or going down on the insulin doses, to make sure that the patients are achieving a proper hemoglobin A1C by the next visit. So really, it is a team that goes around the entire patient, so that we're addressing all the patient's needs. And in our practice, we work with Richmond University Medical Center, and one of the things one realizes when they treat patients that have diabetes is a lot of them suffer from mental health issues. A lot of patients are depressed or have anxiety. So we can, and of course those can be barriers in terms of their treatment of both their diabetes, their hypertension, their hyperlipidemia. If you're feeling depressed, you're not in your normal state of affairs, you might not be that interested in taking care of your overall health. So it's important to plug those people into for mental health counseling and referrals when indicated. So luckily in my office we have the ability to do that pretty easily.
And that's super. Tell us a little bit about COVID-19 and diabetes. There's a lot of aspects to it, patients not coming to the office, the telemedicine approach, the idea that were they going to the lab, patients going to the lab as frequently. So how has it affected your practice in diabetes management?
COVID has affected a lot of things, and certainly the access to the office was very, very significant. A lot of patients were not interested or couldn't get to the office for their office visits. And the telemedicine certainly has enabled us to keep a closer eye on those patients when they couldn't physically be there. Although we were open throughout the pandemic, some people just didn't feel comfortable or didn't have a ride, and they didn't want to sit in the waiting room with other people, which I can understand. The other challenge you allude to is the fact that people weren't getting their labs done. And with diabetes, really, a lot of what we do is based on the objectivity of those labs. I need the patient's hemoglobin A1C. I need to know what their creatinine, their kidney function is like in order to give them different medications. So what we were able to do during the pandemic was able to do some telemedicine. We were able to send labs to the house for some patients, and the labs were very friendly to that approach, and they were willing to go to the patients' houses and retrieve those labs so that we could get the objective data that we really needed to manage those patients. So I think we did a pretty good job. I think we adapted to the situation, but in some sense it's not ideal. I mean, certainly I would like to get a blood pressure on all my diabetes patients, but that of course remained a challenge with the pandemic.
Hopefully things are getting better now.
Fortunately.
Tell us about, with regard to vitamin therapy.
Yes.
So many of our patients want to take natural substance, want to go to the health food store. Some things are, and it's so important that they tell their healthcare provider what they're taking, or else we can get ourselves into a mess in a sense by not knowing. Are there any vitamins or nutraceuticals or anything that you recommend for our patients with diabetes?
With diabetes, we have many pharmacologic therapies. We don't have a giant or good evidence basis surrounding utilization of vitamins to achieve good glucose control. Patients do come, ask about it all the time. I will certainly examine whatever vitamins they give me. And of course, the point of showing your doctor all the vitamins you're taking is critical, because some of those vitamins might interfere with some medications. But if you ask me, is there a particular vitamin to take to make the sugar better? The answer really is no. There's nothing. Of course, in medicine, we always are looking to practice evidence-based medicine. And how do we do that? Well, we take an approach, we compare that to placebo, and we follow those patients for a defined period of time to see what effect these things have. Unfortunately, the vitamins that are out there really have not been subjected to that kind of research. Once they do that, and there is a benefit, we would certainly be delighted to give it to our patients.
And most of us will recommend a multivitamin to most of our patients, especially people over the age of 50, vitamin B complex, things of that nature, because especially in my practice, we're seeing a lot of patients with diabetic nerve problems or diabetic neuropathy. And thank goodness our patients with diabetes are not having as many amputations, vascular disease, or all the other complications because of the wonderful treatments that you've described. So Dr. Otterbeck, thank you so much for enlightening us about diabetes, and hopefully everybody stays safe and does real well.